Hello everyone, welcome to my channel. We have started the preparation for medicine subject. We already covered the units CVS, pulmonology, endocrinology, and rheumatology. Now we are doing the CNS. So the topics that are important in CNS are stroke, subarachnoid hemorrhage, seizures and epilepsy, meningitis, tuberculous meningitis, myasthenia gravis, Guillain-Barré syndrome, and carpal tunnel syndrome. So starting from our next first topic, that is CNS of the CNS, that is stroke. Stroke is very important topic of the medicine, and we will discuss this. The scenario is that there is a 70-year-old man who is hypertensive and diabetic is brought to the emergency with sudden onset of weakness on left side of the body. On examination, he is semi-conscious with no limb movements of the left side and positive Babinski sign on the left side. BP was 190 by 110 and pulse was 104 per minute and irregular, and the rest of systemic examination was unremarkable. Okay, for the stroke, to identify, we must know these points that for from first, that is, there will be face symptoms, arm shift symptoms, and slurred speech will be present, and we should know the time of the stroke, that it is from 30 minutes or 1 hour or etc. So the definition of stroke is that it is sudden onset of focal neurological deficit lasting greater than 24 hours or leading to death with no cause apparent other than vascular one. The types of stroke are ischemic stroke and hemorrhagic stroke. In ischemic stroke, it is seen on the CT scan after 24 hours, and hemorrhagic stroke is seen before 24 hours. The causes or risk factors of stroke are extracranial vessels, common and especially carotid, DVT, atherosclerosis of other vessels, for example, heart and vasculitis. Then the modifiable causes are hypertension, diabetes, smoking, heart disease, estrogen containing hyperglycemia and polycythemia. And the non-modifiable causes are age, male, races, family history, sickle cell disease, and heredity. The clinical features of stroke are rapid onset, focal neurological deficits, myasthenia and ataxia, diplopia, nystagmus, hemiparesis, and facial palsy. The types of stroke are transient ischemic stroke, which recovers in 24 hours. Then reversible ischemic neurological deficit, which is for 1 week. Then permanent ischemic neurological deficit, and then evolving stroke, which occur in the upper limb and then the lower limb, and the complete stroke, which stop at certain point. Then the investigations for stroke are MRI. We will look for vascular lesions, and the CT scan, that is hyperdense area hemorrhage is present on the CT scan, and it is better than an MRI. Then subarachnoid hemorrhage, blood in the CSF, xanthochromia, and CT scan, LP bleeding, cardiac source, and atrial fibrillation. Then we have to know the underlying disease, that is carotid artery, and Doppler ultrasound, then MRA angiography and CT angiography. The risk factors are diabetes mellitus, hypertension, hypercholesteremia, smoking, blood CP, lipid profile, blood glucose level, and serum electrolytes. The unusual causes are ESR, protein electrophoresis, clotting profile, that is PT or APTT, and neuroimaging or heart imaging. Then the management options for stroke are, if patient is present in less than 4.44 hours, then CT scan is done, thrombolysis and thrombolytics are given, tissue plasminogen type. Surgical intervention urgent, which are small hole is done, then endoscopically lysis thrombus is done. The supportive treatment is provided, that is NG tube and Foley's catheter. Then we will treat the underlying cause, that is statins, clopidogrel, and aspirin are given. In ischemic stroke, BP is lowered slowly and gradually, that is 160 to 180. Then if patient is presented after 24 hours or greater than the time of 4.5 hours, then aspirin is given. 300 mg is the leading dose, and the maintenance dose is 75 mg. Then clopidogrel is given. If patient is of fibrillation and develop clot warfarin drug of choice, then oral therapy patient take easily. INR is checked 2 to 3 days. In hemorrhagic stroke, there is increase in intracranial pressure, nausea, vomiting, headache, and blurring of vision is present. Intravenous mannitol is given, which decreases intracranial pressure. Then supportive care is given, that is hydration is maintained, BP is maintained low to decrease bleeding, that is 100 by 70 in 24 to 48 hours. Then surgical intervention are done, that is clipping of the arteries, and platinum coiling is done to resolve the symptoms. The general management is careful nursing, monitor ABC, fluids and nutrition are given, and monitoring is done. The care of the skin is taken, care of the bladder is done, and the bowel and care of the eyes is done. So up till now we have discussed our first topic of CNS, that is stroke. We have discussed the scenario, then the definition, the types, the causes or risk factors. Then we discuss the modifiable and the non-modifiable risk factors. Then what are the clinical features? Then we discuss the types of stroke, that is transient ischemic stroke, reversible ischemic neurologic stroke, permanent ischemic neurologic deficit, evolving stroke, and complete stroke. The investigation options for stroke are MRI, CT scan, subarachnoid hemorrhage, underlying disease, risk factors, unusual causes, and neuroimaging and heart imaging. Then the management options are, if the patient presented is less than 4.5 hours, then the management option for the patient that are presented with greater than 4.5 hours, then the hemorrhagic stroke, then the general management. Now coming towards the subarachnoid hemorrhage, we are having a scenario that there is a patient, a 50-year male non-hypertensive, brought to casualty with the history of sudden onset of severe headache, vomiting followed by consciousness and or examination. BP is 180/20 and drowsiness and neck stiffness is present. So the diagnosis, investigation and management are asked. Subarachnoid hemorrhage definition is that it is a term which describes spontaneous arterial bleeding into the subarachnoid space. Most of subarachnoid hemorrhage results from fracture of the Barré secular aneurysm of one of major cerebral arteries or their branches at the circle of villi. The causes of the subarachnoid hemorrhage are secular, that is Barré aneurysm, which is most common, then vascular malformation, then the hematological disturbances are present, the tumor and the traumatic hematoma is present. The clinical features of subarachnoid hemorrhage are abrupt onset, intense, painful, and thunderclap headache, often described as the worst headache of life, then loss of consciousness in 25 to 50% of the cases. The signs of meningeal irritation, neck stiffness, photophobia, and vomiting is present. Investigations for subarachnoid hemorrhage are non-contrast CT scan, which very sensitive in initial stages and show hemorrhage and diagnostics, and the lumbar puncture, which is an investigation of choice, CSF examination, then the MRI of the brain is done, then the arteriography is done, then the coagulation profile is done, then the CT angiography or Doppler is done, then the cerebral angiography is done, there is dye is injected in brain and x-rays are taken. The management of complications, we are having the hydrocephalus, obstructive delayed cerebral ischemia and hyponatremia. Third, systemic complications are also present. Okay, the management options for subarachnoid hemorrhage are general management and specific management and surgical management. In general, we will do the careful nursing, then ABC monitoring is done, fluid maintenance is done, bladder bowel care is done, and control BP to prevent rebleeding. Then antihypertensive drugs are given, that is intravenous beta blockers and calcium channel blockers, for example nimodipine. Then phenytoin are given for seizures. Nimodipine, that is calcium channel blockers, and arteriovenous malformation, surgical approach is done, ligation, injection of the material of occlusion is done. Okay, the surgical options are surgical clipping of the ruptured aneurysm, coiling is now procedure of the choice, and treatment according to the cause, for example clipping, platinum coil, and arteriovenous malformation. So we have discussed the subarachnoid hemorrhage, the scenario for subarachnoid hemorrhage, then we discussed the definition, the causes, the clinical features, then the investigations, which are non-contrast CT scan, lumbar puncture, MRI, brain arteriography, coagulation profile, CT angiography and Doppler, and cerebral angiography. Then the management of the complications, the management, that is general, the specific, and surgical approaches, and the treatment according to the cause. Now coming towards the next topic, that is seizures and epilepsy, which is the most important topic of the medicine, CNS. We are having a scenario that there is a 27-year-old taxi driver brought to OPD by his father, who gave history that his son has 2 episodes of loss of consciousness in which his body becomes stiff, initially followed by generalized jerky movements with frothing and tongue bite. Clinical examination is unremarkable. Another scenario is that there is a 20-year-old patient, 5 episodes of sudden loss of consciousness in last 1 year. According to eyewitness account, during the attack, he becomes cyanosed, his jerky movements of the whole body with frothing of mouth and tongue bite. On examination, he is afebrile, BP is 115 per 70 mm of Hg, and no neck stiffness and fundi are normal. So the diagnosis, investigations, and the drugs with side effects used in treatment and advice to patient and relative. So first we will define the seizures and epilepsy. Seizures is abnormal paroxysmal excessive discharge of CNS neurons. Epilepsy is recurrent unprovoked seizures due to chronic underlying process, and the types are focal cone area of brain is involved, and in generalized the overall brain is involved. We have 2 types, focal and generalized. In the focal, one area of brain is involved, and generalized overall area is involved. Focal seizure frequency is 2 to 3 times fits in 2 to 3 times minutes, and Status epilepticus duration is 10 minutes. Psychiatric triggering factors are alcohol withdrawal and infection, aura, post-ictal symptoms, and drowsiness, amnesia after seizures. The second is generalized seizure. Causes are structural lesions, metabolic disorder, inflammatory disease, and infective and genetic. The investigations are for single seizures are ECG, that is secondary to cardiac abnormality. Then MRI is done for abscess, tumor, hematoma, and hydrocephalus. CT scan is done. EEG is done for seizure specific, and then in case of positive family history, abnormal neurological examination can lead to recurrence. For infective metabolic causes to find cause, then the investigation for general are arising standard EEG, sleep EEG, special electrodes, ambulatory EEG, and video automated EEG is done. For structural lesions, CT scan, MRI is done. For metabolic, LFTs, RFTs, electrolytes, glucose level, and fasting and randomly is done. For inflammatory or infectious blood, CP, ASR, CRP, and raised in case of infection, and chest X-ray is done. And true epilepsy is done for EEG, ambulatory, and video assisted EEG. Okay, the management options are first aid, providing first aid, that is during attack after 5 minutes. Then the supportive measurements are done, that is prevent patient from harmful area. If tongue bite, not disturb patient. Left lateral position to prevent aspiration, clear airways, and if not recover in 5 minutes, then hospital. Lifetime advice is prevent driving, pilot, firefighter jobs are not allowed, and stay away from triggering factors. The immediate care is assess BP, pulse, temperature, monitoring of vitals, ensure airway is clear, give auto intravenous fluids, give intravenous anticonvulsants, diazepam, phenytoin, phenobarbital, benzodiazepine, and sodium valproate. Treat the underlying cause and the avoiding of precipitating factors. Then the anti-epileptic drugs are given, which are first line treatment, that is lamotrigine, sodium valproate, ethoxyzumab, and valproate. Epilepsy surgery is area of the brain of epileptic focus is removed, and the surgical stimulation of vagal nerve that controls seizure. The counseling for seizure patients are educate them about the nature of the disease. Then appropriate information about drug interaction is given. Appropriate first aid is provided. Avoid alcohol, avoid swimming. Appropriate information about driving and control measures, and avoided if area of epilepsy is felt. Avoid walk in factories having heavy machineries, and clinical features are episodes of loss of consciousness, abnormal jerky movement of the body, frothing of the mouth, body stiffness initially, tongue bite, and incontinence of the urine. So we have discussed the topic seizures and epilepsy. Then we have discussed the scenario. Then what are seizures and what is epilepsy? Then the types, which are focal and generalized. Then we have discussed the focal and generalized introduction of the both. Then what are the causes? The investigation options for single seizures, which are ECG, MRI, CT scan, EEG. For infective and metabolic causes. Then for general arising structural lesions and metabolic, inflammatory, or infection, and true epilepsy. Then the management options: the first aid, the supportive treatment, the lifetime advice, the immediate care, and then the anti-epileptic drugs first line. Then epilepsy surgery is done, and the counseling for the patient, and then the clinical features for the patient. Now coming towards another and the most important and common topic, that is meningitis. This is very important topic. We are having a scenario that there is a 20 years old girl brought to casualty, complain of fever, headache, and vomiting for the last 3 days. On examination, temperature is 102 degree Fahrenheit and neck rigidity. She is irritable. Systemic examination is unremarkable. The scenario for meningitis, another is 16 years old, 1 day history of severe headache, fever, vomiting. On examination, she is febrile, disoriented, neck rigidity is positive with purpuric rash on hands and legs. Okay, so the definition of meningitis is that it refers to the acute bacterial inflammation of leptomeninges and CSF within subarachnoid space. Then the causes of meningitis are bacterial, viral, fungal, protozoal, streptococcus, pneumonia in neonates, E. coli, and group B streptococci. In adults, Neisseria meningitis and S. pneumonia is present. In elderly, streptococcus pneumonia, listeria monocytogenes is present. The clinical features of meningitis are high-grade fever, headache, neck stiffness, photopia, altered consciousness, nausea, vomiting, seizures, nuchal rigidity, and Brzezinski signs. The investigation options that are done for meningitis are baseline, which must be done, then blood CP is done, that is infection may present, leukocytosis, ESR, and CRP. LFTs and RFTs are done for other organs. Diagnostic test is lumbar puncture. The CT scan is done to rule out mass or hydrocephalus, wide and vertical mass lesions, abscess, tumor. Blood culture is done for bacteria, and DNA PCR is done for LP from blood CP. For LP, increase cell count, increase protein, decrease glucose, gram staining of CSF, and CSF culture is present. The interpretation of CSF results is done is if the color is checked, that is subarachnoid hemorrhage, then cytochromia is present, neutrophils are checked, viral, glucose, and protein levels are checked in the CSF. Now the scenario Okay, the management options for meningitis are specific, which are specific and for viral, supportive analgesics, antipyretics, and unless encephalitis, if encephalitis, then acyclovir is given. For bacterial, intravenous benzyl penicillin third generation ceftriaxone and cefotaxime is given. If patients are resistant, then vancomycin and rifampicin is given. If infection is caused by listeria, then ceftriaxone plus vancomycin and rifampicin is given. Associated therapy to prevent cerebral edema and tuberculosis is ATTT, that is 18-month course. IRAP plus steroids. The specific treatment for meningitis is best initial treatment is intravenous ceftriaxone 2 gram to 12 for day. 12 folly steroids are given, that is dexamethasone therapy. Patients with typical meningococcal infections, that is perpuration, benzyl penicillin 2.5 gram intravenous is good given 6 hourly. Meningococcal infection connects positive, then can't straight oral rifampicin for 2 days or single dose of ciprofloxacin is given, and meningococcal vaccine is also available. The complications of meningitis are deafness, cerebral edema, subdural empyema, hypothermia, and hydrocephalus. So we have discussed the most important topic, that is the meningitis. We have to check for the Koenig sign, Brudzinski sign, and the nuclear rigidity. The definition of the meningitis, and we discuss the causes in adults and in elderly, and the clinical features and the investigations, which are baseline, blood CP, LFTs, RFTs, diagnostics, CT scan, blood culture, and DNA PSR. Then the interpretation of the CSF result, the color, the neutrophils, viral glucose proteins are checked. Then the management options, which are specific are for viral and for bacterial, and the complications, we have discussed the complications. The another scenario that there is decreased glucose and 500 polymorphs. Diagnosis is bacterial. Highly elevated lymphocytes, mild increased protein lymphocytes, and 100 lymphocytes protein or glucose is normal. So in meningitis, we have usually the increased protein and decreased glucose present. So this is the diagnostic point. Now coming towards the next topic, that is tuberculous meningitis. We are having a scenario that there is a 22-year-old man and he is brought to A&E department by his father with a history of low-grade fever, cough, and headache for last 4 months. On examination, patient has altered consciousness and neck rigidity, chest ratio, miliary shadowing. Diagnosis, investigation, complications, and the treatment of tuberculous meningitis. Now the investigations are same as other, but add X-ray chest for pulmonary TB, Montauk's test and ESR, and sputum culture and sensitivity is done. The treatment option of tuberculous meningitis are 4 drugs, that is isoniazid, rifampicin, ethambutol, and pyrazinamide. Anti-tubercular drugs for 12 months are given: isoniazid, rifampicin, pyrazinamide, and ethambutol. And then 3 drugs are given for 10 months, which are with and the withdrawn drug is pyrazinamide. Okay. The additional drugs that are given are corticosteroids, that is dexamethasone, and vitamin B6, that is isoniazid, and toxicity and pyridoxine, which causes toxicity. Okay, the complications of tubercular meningitis is hydrocephalus, cranial nerve palsy, brain stroke, and seizure disorder. The surgical treatment are in case of severe hydrocephalus, one can go for VP or VA shunt. Okay, INH dose is 5 mg per kg per day. Rifampicin is 10 mg per kg per day. Pyrazinamide 15.30 mg per kg per day. Ethambutol 25 mg per kg per day. And pyridoxine is 50 mg per day. So we have discussed the topic tuberculous meningitis, the scenario of the tuberculous meningitis, then the investigation options, the treatment, then what are the additional drugs that are given, then the complications, and then the surgical treatment. Now coming towards the next topic, that is myasthenia gravis. This is a very important topic, and we are having a scenario that there is a 30-year-old female came to OBD with history of recurrent weakness of limbs and diplopia. She feels better in the morning and her symptoms are worse as day passes. On examination, has bilateral ptosis with the rest of examination is unremarkable. Then another scenario is that there is recurrent weakness of limbs and diplopia, symptoms worse in evening and less in morning. On examination, bilateral ptosis is present and the neurological examination is unremarkable. So the definition of myasthenia gravis is that it is autoimmune disease caused by autoantibodies against postsynaptic acetylcholine receptors, type 2 hypersensitivity reaction. Okay, this is a type 2 hypersensitivity reactions and autoimmune disease which is caused by the antibodies against postsynaptic acetylcholine receptors. The clinical features of myasthenia gravis are muscular weakness, fatigue, decreased weakness in the morning, and increased decreased weakness in the morning and increase in night, elevate with standing, relief with sitting, eye ptosis is present, diplopia is present, and it is associated with thymoma. The investigations for Myasthenia gravis is penicillin test, that is indirect short-acting cholinergic agonist. Idrophonium is given. Electromyography is done to see response on nerve stimulation bedside. Then antibodies level are checked. Acetylcholine receptor antibody 80 to 90% in acute is anti-musk antibody. X-ray chest and CT chest to exclude the myoma. The treatment options for myasthenia gravis are cholinergic agonists are given to increase the acetylcholine hormone, that is anticholinesterase. Acetylcholinesterase inhibiting drugs, that is neofustigmin, is given. Plasmapheresis is done to decrease the receptor antibody in plasma. Intravenous immunoglobulins are given, which is the acute management. Chronically prednisolone to suppress immunity is thiopurine and cyclophosphamide, and if it is associated with thymoma, then thymectomy is done. The complications are myasthenia crisis, respiratory failure, cholinergic crisis, dysphagia, and drooping eyelids and double visions. Okay, so we have discussed the topic myasthenia gravis, the scenario, then the definition, the clinical features, and the investigations, which are penicillin test, hydrophonium electromyography, antibodies level, X-ray chest and CT chest. Treatment options are cholinergic agonist, plasmapheresis, intravenous immunoglobulins, chronically, and complications. Now coming towards the next topic, that is Guillain-Barré Syndrome. We are having a scenario that there is a 23-year-old female admitted with 2 days history of symmetrical lower limb weakness and prosthesia. Since morning she is complaining of difficulty in coughing and stiffness of face is present. 2 weeks previously she had short-lived episodes of upper respiratory tract infections. Another scenario is that there is a 20-year-old symmetrical weakness in lower limbs, difficulty in coughing, history of upper respiratory tract infection about 10 days is present. On examination, power of 4/5 with absent reflection in lower limbs, no history of trauma. The diagnosis, investigation, and complication and treatment options are okay. So the definition of Guillain-Barré syndrome is that it is acquired autoimmune post-infectious or idiopathic polyneuropathy with symmetrical flaccid motor weakness and minimal sensory involvement, typically associated with raised CSF protein but no cells. Major features of Guillain-Barré syndrome are weakness and areflexia. There are ascending paralysis. Okay, the clinical features of Guillain-Barré syndrome are history of gastroenteritis or upper respiratory tract infection, that is Campylobacter, symmetrical lower limb weakness, and absent reflexes. Investigations for Guillain-Barré syndrome are clinical diagnosis. Diagnostic criteria is progressive symmetric weakness of one limb, then hyporeflexia or aeroreflexia, then progression less than 4 weeks, and symmetric weakness. EMG and nerve conduction tests are done. Conduction block, decrease F wave, and lumbar puncture is done to check for normal WBC and elevated CSF protein. Okay, now so coming towards the management of Guillain-Barré syndrome, we are having supportive care, which is regular monitoring of the vitals, especially respiratory function. Intravenous immunoglobulins are given. Plasmapheresis is done. Glucocorticoids not effective for Guillain-Barré syndrome but give respiratory support. Ventilated support if vital capacity falls below 1 liter, and heparin to prevent complications. Life-threatening complications of Guillain-Barré syndrome are respiratory failure or arrest due to weakness of respiratory muscles, cardiac arrest, and septicemia. Okay, so we have discussed the case of Guillain-Barré syndrome, that there is a patient admitted with 2 days history of symmetrical lower limb weakness and paresthesia. Since morning she is complaining of difficulty in coughing and stiffness of face is present. 2 weeks previously she had short-lived episodes of upper respiratory tract infection. There is a history of past respiratory infection, and now she is having the difficulty or limb weakness of the lower limb. So it is autoimmune disease in which the symmetrical flaccid motor weakness occur and minimal sensory involvement, typically associated with raised CSF protein but no cells. Major features are weakness and areflexia, and there is ascending paralysis, which is symmetrical. So the clinical features and investigations are discussed. Then we discuss the supportive care, and then we discuss the life-threatening complications. Now coming toward our last topic of the CNS, which is carpal tunnel syndrome. We are having a scenario that there is a middle-aged obese pregnant lady in her 3rd trimester presented to physician with complaints of pain and tingling affecting right hand, forearm, and shoulder. Pain is severe enough to compel her to stop working. Symptoms worse at night but get relieved by shaking hand. Her blood sugar level is normal. RA factor is negative. X-ray right hand including wrist joint is normal. So what is the diagnosis, investigation, and the treatment? The definition of carpal tunnel syndrome is that it results from compression of the median nerve at level of wrist within the carpal tunnel, more common in women and is frequently bilateral. The investigation options are nerve conduction studies. It shows reduce or stop median nerve conduction as compared to other nerves. Then CT or MRI shows compression of the median nerve. Then Doppler studies may be normal. Electromyography is done to minimal to no which show minimal to no denervation, and ultrasonography is done. Then the treatment options are general measures, which are Stop activities that cause numbness and pain. Rest your wrist. Ice your wrist for 10 to 15 minutes or 2 times or wear with splint at night. So another scenario is that there is a 60-year-old came to OPD with complaint that he developed certain loss of vision in left eye. This morning attack lasted for 3 to 4 minutes with complete recovery of vision. He had similar attacks in the past from last 6 months. Another scenario is that there is a 60-year-old diabetic patient. Weakness of the right side of body and difficulty in speech for last 2 hours is present. Weakness resolved in 30 minutes and speech also become normal. Had suffered 2 similar episodes in last 3 months. On examination, BP is 130/90 and pulse 90 per minute and irregular. No neurological deficiency is present. Diagnosis, justified diagnosis, causes, treatment, investigation. So the definition is that it is characterized by sudden onset of the focal neurological deficits due to cerebral ischemia. There is no stroke on imaging and symptoms resolve within 24 hours. The causes are valvular heart diseases, atrial fibrillation, MI, and hypertension. Then the diabetes mellitus, the hypercholesteremia, the erytheromatous plaque. The investigation options that are done are blood CP, FB sugar, serum cholesterol, ECG, X-ray chest, and echo and carotid Doppler. The clinical features are conscious, preserved, sudden loss of function in one region of the brain, and weakness, numbness in arm, leg, or face, and visual loss in one eye. The treatment options are medical treatment, which aim to prevent further attacks and stroke, then immobilization from heart, that is anticoagulant heparin followed by warfarin. If anticoagulant are contraindicated, then aspirin or statins is given. Immobilization from extracranial intracranial cerebrovascular circulation is done, that is aspirin or clopidogrel is given. If if the patient is allergic to aspirin and clopidogrel is given. The surgical options are not indicated in mild cases, but endotherectomy reduces risk of stroke and is indicated when carotid artery is severely stenosis. Subcutaneous angioplasty is done in patients who are not suitable for surgery. Okay. So we have discussed the carpal tunnel syndrome, the scenario, the definition, investigation, and the treatment options, and the causes, the investigations, the clinical treatment, and and the surgical treatment options. So here we have covered our unit of CNS. We have discussed the following topics, that is stroke, subarachnoid hemorrhage, sinus, seizures and epilepsy, meningitis, tuberculous meningitis, myasthenia gravis, Guillain-Barré syndrome, and carpal tunnel syndrome. In the next video, we will discuss psychiatry portion, which is the last portion of medicine A. Then after psychiatry, we will start the medicine B subject. Thanks for watching.